up, guys? Today is a Sunday morning, in fact, early morning. Uh, anyway, so we will be dealing with drugs for diarrhea or pharmacotherapy of diarrhea for today. Um, yes, diarrhea, as you must be knowing, it is not a disease but is a symptom of some underlying problem with the gut or the GIT, whatever you call it as, and the frequency of stool is more than normal in these cases, as well as the stool consistency is thin and watery. So then you call it as diarrhea. Coming to few causes of diarrhea, diet, okay, overeating sometimes do cause indigestion and diarrhea. Infants lack an enzyme called as lactase required for digestion of specific foods or liquids, which is genetically origined and gives rise to diarrhea. Infections, again, a very important cause for diarrhea. We have bacterial infections, a lot of bacteria, right? E. coli and so on. Viral causes of diarrhea. In fact, the most important in under 5 gastroenteritis is rotavirus. Fungal infections, opportunistic fungal infections in immunocompromised individuals can cause diarrhea. In fact, there are few parasitic causes also of why a person should suffer from diarrhea. A few toxins present within the food or as such or secreted by the organisms, and they have the ability to cause diarrhea. A few drugs have the ability to cause diarrhea. In fact, they disrupt the normal flora if you talk in terms of broad spectrum antibiotics, and then cause diarrhea. A few stress factors, irritable bowel syndrome, so on. A few other autoimmune diseases like Crohn's disease, ulcerative colitis, and a few other diseases of the GITs also cause diarrhea. But I'm not going to list those because that goes then it's a never ending list, and we are here to just learn about drugs, that too general drugs for diarrhea. So broadly speaking, these are a few diseases in which a person suffers from diarrhea. Now, coming to the classification of diarrhea, we have something called as acute diarrhea, which is sudden onset. Now, acute diarrhea, especially due to toxins or infections, um, you know, traveling from one part of the world to the other part, change in water and food, and people suffer from diarrhea. So, a lot of causes for sudden onset diarrhea. In fact, it is one of the commonest problems the people face around the world of getting diarrhea. Again, bacterial causes, viral causes, and so on also adds on to acute onset of diarrhea. Then we have chronic diarrheas. Basically, these are due to gut pathologies. So here we have inflammatory bowel disease, that's IBD, stress-related problems, irritable bowel syndrome, and so on. So the list is like more of medical pathologies, wherein the diarrhea remains for a very long time. So that's a quick look and classification. And now, if you think in terms of drugs which are used for diarrhea, broader ways, I'm not talking of specific drugs for ulcerative colitis, Crohn's disease. No, we will come to those uh, sessions separately. But as of now, if we generally look at drugs which are used for diarrhea, there are few treatment goals. We need to rehydrate the patient because diarrhea is loss of fluid and electrolytes. So we need to replenish those losses. So it's all about rehydration of the patient, because rehydration makes the patient well again, healthy. Uh, it might be that the diarrhea just continues, but then again the patient can survive through that episode if he's rehydrated well. Then we have control the losses of fluid. Okay, we want some drugs which can control the fluid loss. We want to stop the diarrhea at one point because we don't want excess of water and electrolytes to go out of water. A treatment of the cause, so you need to identify, treat the cause, and provide some symptomatic relief, because it's a GIT problem. So GIT problem is, maybe the patient only suffers from diarrhea, but at times the patient might also suffer from nausea, vomiting, some other issues related to hypovolemia. So you need to cover up for those symptoms. So you need to give some symptomatic relief. Abdominal pain can be associated with diarrhea. So a few drugs which can also be given to tackle those symptomatic issues related to patients with diarrhea. So that's also a priority when you're treating diarrheas. Now, the basic treatment, okay, for all kinds of diarrheas is oral rehydration therapy. Now, remember, we can replenish losses with the help of IV fluids, but that doesn't put down oral rehydration therapy. No, it's gold standard therapy, and as a doctor or as health professional, you should be aware about this therapy, because this is something which is a standalone therapy for diarrhea, and reduces morbidity and mortality associated with diarrheas um, to a wider extent. So we talk of oral rehydration therapy, and when we talk of oral rehydration therapy, again we split the term. It's oral, so something which is orally given, and rehydration, so you want to rehydrate the body by fluids, right? By fluids, and it's a kind of therapy because you are trying to treat dehydration, which is the basic cause of worry in any kinds of diarrhea. So the aims of therapy would be to correct water and electrolyte deficiency, because that is what is going out of the body, so give it back, but by oral route. To prevent dehydration, yes, because dehydration itself brings about a lot of medical issues related to hypovolemia. So yes, we need to prevent dehydration by giving oral rehydration therapy. You want to also reduce mortality, because if you just notice the number of people dying out of diarrhea, especially you talk of extremes of ages, small children less than 5 years, or you talk of elderlies, then it's a huge population who is at risk, and the mortality rates are like very high. So you want to prevent mortality, and just introduction of this oral rehydration therapy a few decades back was a magical transformation in bringing down mortality associated with gastroenteritis, especially in children. So it was a huge benefit. In fact, it's kind of a discovery which you invention which you can relate to any other big scientific discoveries in the last century. So there it stands to oral rehydration fluid. It has saved millions of lives till now, in the developed as well as the developing countries, even to extent in the underdeveloped countries, quite cheaply available. So it reduces mortality. That's the point I need to make when you talk of oral rehydration therapy. When you talk of mechanism of action of these drugs, then it's all about the sodium glucose co-transporter pump that you are talking. The brush border epithelium of the intestine contains or it consists of a few transporter pumps. One of that is the sodium and glucose co-transporter pump, and the intactness of this pump is even in the case of very severe diarrhea is the fact that uh, we have introduced the oral rehydration therapy. So we take that into benefit, and we introduce the oral rehydration therapy. So what exactly happens is that this co-transporter pump is meant for glucose, but glucose along with it carries sodium in the ratio of 1:1. So one molecule of glucose to one molecule of sodium, and where sodium goes, even the water gets absorbed. Go back to fundamentals of what happens with transportation of molecules in physiology, and you might be learning more about that. But so you absorb more sodium, more water comes inside. So in fact you are trying to put in glucose, sodium and water by taking help of the sodium glucose co-transporter pump. We correct electrolyte deficiencies as well as water deficiencies by uh, giving oral rehydration therapy, because oral rehydration therapy also contains sodium and glucose. We'll come to it, but that's the mechanism of action that you're talking of when you are dealing with oral rehydration salts, and when you give oral rehydration therapy to these patients. Now a few things that come to my mind when I talk of oral rehydration therapy is all about reduced osmolarity ORS. So when oral rehydration salts as therapies were invented, or when were they introduced, I should say, not invented, the osmolarity was quite high. So at times it was not beneficial for the patients. So WHO came up, that is the World Health Organization came up with a new formula for oral rehydration therapy in the form of oral rehydration salts, and this formula is of reduced osmolarity. Okay, reduced osmolarity, and this formula works efficiently, and the efficacy data associated with the use of this new ORS is something which stands when compared to the older ones higher in its value as compared to what is the older one. But definitely we are not looking at cholera associated diarrheas. Again, cholera is a big issue in the developing and underdeveloped countries, so we are not talking of those issues. In cholera associated diarrheas, in conventional ORS, that is higher osmolarity ORS is used. Please bear this in mind. But for other diarrheas, the reduced osmolarity ORS is what is used, and that's the osmolarity that we are looking at. So sodium is 75, chloride stands to 65 millimoles, glucose at 75, potassium 20, citrate is 10 millimoles. So total is 245 millimoles. So that's the osmolarity of reduced ORS that we are looking at. Now that's the new formula of WHO. So you might find across ORS preparations in primary healthcare centers in your countries, so you might find this kind of osmolarity. Just try to see the contents and you will find the same thing onto that. So that's the new ORS formula that we are looking at. Now if you look into the gram contents, NaCl is around 2.6 in reduced osmolarity ORS, glucose is 13.5, KCl that is 1.5, and trisodium citrate is 2.9. Now why we want, in addition to glucose and sodium chloride, potassium and trisodium citrate, is that these electrolytes are also lost. So we want to replenish potassium, we want to replenish chloride, and that's the reason that you need to add chloride and potassium in this composition. Again with trisodium citrate. Now trisodium citrate is actually a substitute for sodium bicarbonate. The use of sodium bicarbonate was there a few years ago in ORS, but then sodium bicarbonate forms some kind of a brown color compounds when it was mixed with ORS and kept for a long time. So to reduce on that, actually sodium citrate was added to the components. It's a base substance. It's basically to correct associated acidosis due to alkali loss in the stools. So alkalis are lost, so it's basically to tackle the acidosis of the body that you need to add sodium citrate. Now there is a big debate on whether you want to have sodium citrate in hand in the ORS preparation or not, because body is self-sustained to manage the acidosis associated with alkali loss. But in severe cases, yes, you require some bicarbonates to be given, and maybe that's the reason that it still exists in ORS preparations. Again, a point to be remembered is that it might increase also the shelf life of the entire sodium what is not sodium sodium no, hey, come on, forgetting something, shelf life of ORS preparation, sorry for that. Okay, so yes, so it's required, right? So that's the gram concentration of all the components when you look at the ORS salts. Try to look for the gram content as well as the osmolarity on the sachets of ORS preparations. Now ORS is available as powder. You need to mix that powder, prepare a solution in water, in around 1 liter of water. So one sachet you need to mix in 1 liter of water. This water you can keep it for the next 24 hours. Now remember, ORS is basically for a mild to moderate dehydration. If you have a patient with severe dehydration, then definitely IV fluid stands a better chance. So for mild to moderate water loss, you need to replenish it by giving ORS preparation to the patient. There are several advantages of why you want to use ORS, because increased efficacy of ORS is seen in non-cholera diarrhea, especially low osmolarity diarrhea. It decreases the stool output, so that's what is also and safe and effective. So with ORS we are actually not trying to uh, prevent, not I should say prevent, treat or diarrhea. We are just trying to treat the dehydration associated with diarrhea, because most of the times it's the viral origin diarrhea, especially in small children. So it's kind of a self limiting factor, but the loss of fluid is what worries me as a doctor. So I want to replenish the patients for the losses. So my ORS preparations will just try to replenish the dehydration which is caused by a diarrhea. So that is also you need to remember when you talk of ORS in general. In addition to this, the next slide would be on the dosage. So if you now look at the dosage here, we talk in terms of age and weight. Now as the age of a person increases, yeah, the weight also increases, right? It's logic, huh? I'm just talking of the normal increase in weight. I'm not talking about obesity. So age is relates to weight, because see, less than 4 months is less than 5 kg, but as you move on with the age, even the weight goes on increasing, and so is the solution which is required. So for less than 4 months with diarrhea, maybe you want to require you what you require is 200 to 400 ml of ORS. Now as you go on increasing on the age and the weight, definitely the requirement of ORS also increases. So see, at 15 years it is around 2 to 4 liters of ORS might be required to stop to rehydrate the patients with mild to moderate diarrhea. So that's what I was talking of when you are talking of ORS. Now ORS is given, as I said, you need to make a solution of the salts available in 1 liter of water. If you talk in terms of what kind of water, then I should say it's boiled water and then cooled. So it should be what is called clear in consistency, not something which is turbid. So the water should be clearly one which is drinkable. So that's the point that I want to make here. And keep on giving ORS sip by sip. At times it can happen that the small children might vomit ORS, but then as a doctor you should be counseling parents and other health professionals that you require to keep on giving ORS even if the child vomits ORS. Just try to give it. Maybe you want to reduce on quantity of ORS, so reduce on the spoon size, maybe then it becomes effective if the patient is vomiting, but please keep on giving. There is at no point refusal of ORS, so just continue ORS even if it gets vomited, because some quantities may remain in stomach and that might get absorbed, and that might help the patient to come up from the dehydration the patient might be suffering from. So actually there is no contraindication as such for cases where you shouldn't be using the ORS, right? So other than that, ORS can also be used in patients with heat stroke. We are talking of very high temperatures, and uh, at times patients might get heat stroke, so they might get dehydrated. So replenishing the losses of electrolytes and water, here not through the idea but through sweat and so on, you require to give ORS. So that's one more additional use of ORS as apart from diarrhea, that also comes to my mind when I'm talking of ORS. Now there's something called a super ORS also. Now if you are new to my channel, please go and watch my video on gastroenteritis under 5 where I talked about super ORS. But just a point I need to mention about super ORS is that you can add rice to ORS, and you can make something called as super ORS, right? In fact, rice contains what you call it as starch, which is slowly hydrolyzed at brush borders, uh, and that gives rise to glucose, and this glucose is then made available for sodium to get absorbed. So in fact you are providing more amount of glucose, so glucose along with sodium in the ORS, and it gets absorbed. Rice is cheap, so make rice porridge, okay, so in liquid consistency, and just add to ORS, and then you call that as what is called as a super ORS, okay. We are talking of community-based medicine here. No? ORS is or oral dehydration therapy is not something that we're talking of very tertiary level uh, teaching hospitals, university hospitals. No, we are talking of grassroots level therapies, but which have the therapies which have the capacity to control morbidity and mortality in millions. Uh, uh, if you talk of gastroenteritis, diarrhea, and so on. So we are talking of cheaply available products. So why not add just rice porridge to ORS solution and make it something called as a super ORS, which is highly beneficial, more efficacy as compared to the normal ORS. Rice is anyway available across the globe, so should not be an issue. There were a few studies carried out in this regards with the use of certain other amino acids, taking into the fact that we have co-transporter mechanisms along of sodium along with other amino acids also, like glycine, um, which amino acid, okay, glycine, okay, glycine, so glycine with sodium. But again, the efficacy of this kind of ORS was not to that extent of what the rice would add to. So just we stick to rice porridge as addition to ORS and make it a super ORS. You can also make ORS at home. Yes, a liter of water plus addition of salt and sugar, and you can make homemade ORS if you are in a condition where you have no access to medical help. So that's something of an educational part as far as ORS is concerned. So that was about ORS in general. The next drugs in the list, uh, now these all drugs which I'll be talking through are just supportive managements. They may not help to extend to stop diarrheas, but then again they exist, so I need to make a point of just giving you information on that. We have locally acting agents which are adsorbents. Okay, so these are kaolin, activated charcoal, kaolin plus pectin. But remember, few of these drugs are also banned in a few countries because the efficacy of these drugs is doubtful. So um, they are available in powder dosage form and needs to be taken by the patient. They adsorb bacterial toxins, binds water, and decreases mucus secretion. So that's the way they act and reduce the stool frequency and the loss of fluid. And as I said, efficacy wise it's still in doubt. A few studies says yes, they are helpful, but a few say no. So it all depends upon the doctor's experience of whether you want to use any of these drugs or not. And diarrhea, we have anti-secretory medications. Now anti-secretory medications, the first one would be bismuth subsalicylate. It's available as suspension, and it should be given around 50 to 60 ml per 6 hours. So 6 hours is 6 by 12, 18, 24, so 4 times. Okay, right? So 3 to 4 times as suspension. So orally available suspension of bismuth subsalicylate. It is anti-secretory but also adsorbs bacterial toxins. Sorry for that. So decreases secretion of fluids in the intestine and inhibits the activity of bacteria. If you want to note how it acts, then it decreases prostaglandin synthesis in the intestinal mucosa and thereby decreasing chloride secretion. Okay, so blocks prostaglandin and in turn blocks chloride secretion. So that's the way it acts. But again, as far as where you can use it, uh, where traveler's diarrhea, yes, traveler's diarrhea you can use bismuth subsalicylate. uh, Anywhere else, yes, where there's hyper secretion you can use bismuth salicylate, but again efficacy wise still in doubt whether you want to use this drug or not. We have specialized agents like octreotide. Octreotide is given by subcutaneous route. It's a somatostatin analog. It has anti-secretory and anti-motility action, and octreotide is used for diarrheas associated with carcinoid, associated with VIP, that is vasoactive what is the intestinal peptide secreting tumors. So those kinds of diarrheas you can use octreotide. There is one more use, remember, can't remember. Yeah, it's associated. It can be used also in AIDS associated refractory diarrheas with AIDS. Okay, so there you can use octreotide. So a specialized drug, not in routine practice, but it exists. So I need to make a point that you want to use this drug, especially for some special cases of diarrheas. We also have absorbents. Remember, absorbents as such, we don't use them, but it's mentioned in theory. So these are bulk forming agents. They absorb water and swell. Okay, so once inside the GIT, they will swell, absorb water, and that's the way they modify stool consistency, bring it back to normal. Again, efficacy wise, still in doubt. Some people might find it helpful, some might feel it's not of help. So you can use this methyl cellulose, Isabcula, and so on as absorbents for treatments of diarrhea. A few more drugs, anti-motility drugs. Now, the first point I need to make is anti-motility drugs are not for infectious diarrhea. So, when you think of infection as a cause for diarrhea, you are saying to going to say no to any anti-motility drugs. We have diphenoxylate, loperamide, codeine. Diphenoxylate is OPM-like drug. It has some addictive properties. It can be used as anti-motility drugs. We have loperamide, again a very cheap drug. It's what you can say, it acts on the opioid receptors and prevents motility, uh, or reduces motility of the intestine. It also has a centrally acting what you can say action which inhibits defecation center or reflex. That's the reason that it can be given in a few diarrheas. Codeine, again, codeine is of limited use because of tolerance, addiction, and withdrawal. In fact, I never use codeine for diarrheas, but a few books do mention codeine, so need to mention it here. Yes, but loperamide and diphenoxylate are choice of drugs if you want to use anti-motility drugs. Now remember, again I'm telling you that it's not for infectious diarrheas. If you try to inhibit intestinal motility in case of infection diarrheas, the infection might just spread, and in fact the case can worsen. So you are not supposed to do that. So no to anti-motility drugs in infection origin diarrhea, but for other diarrheas, anti-motility drugs are of choice. We have loperamide as the cheapest one, which is available with us. Orally available tablets again of loperamide. Um, it's like a maximum of 10 milligrams in a day can be given. Okay, so basically for chronic diarrheas, right? So it's orally available tablets of loperamide, very cheaply available, at least in the country where I stay. We have addition of this drug, newer drug, which is called as Racecadotril. It's a peripheral enkephalins inhibitor. It's prevent degradation of endogenous enkephalins, so it acts through them, increases the quantities of enkephalins by preventing their degradation, and in turn it reduces intestinal hypersecretion, but not more. That's important. It doesn't reduce on motility, but just affects secretions. It's not contraindicated in children. The reason is simple. It is not going to affect the motility, but just it will decrease secretion. In fact, that's the reason that you find Racecadotril being used, and now finds its place even in guidelines for treatments of diarrhea, especially viral diarrheas. It comes with a few side effects of drowsiness, nausea, flatulence, indicated as acute secretory diarrheas. Now, this is a recent drug, right? So, a few doctors may be aware of that, may not be aware of that. So, but anyway, as the years pass, as a few more studies come in, I think there will be more solid data on the use of these drugs. But as of today, the efficacy of these drugs, the safety of these drugs is still questionable, but people have been using that. So a few people find it to be really helpful in preventing dehydration, stopping diarrheas. In fact, it reduces to extent, I should say, hospital stay for the patient. So might be in the years to come, this might add on as a major drug for treatment of diarrhea, even in even in children, as well as other causes for diarrhea. The basic is that it doesn't reduce motility. That's the sequence. It just reduces secretions, but it's not something on motility, and has inhibitory action on enkephalinase. So that's important when you talk of Racecadotril. A few more drugs. Probiotics, we have pre-probiotics, prebiotics. Prebiotics is food, probiotics is bacteria, the good bacteria. GIT harbors good bacteria, and that are called as probiotics. Several bacteria, right, and considerable safety data is available for the use of these bacteria. Prebiotics is food, so addition of prebiotics is not a major thing, because we talk in terms of probiotics always. Prebiotics not found to be so efficacious, but probiotics, yes, when you talk of reducing diarrhea episodes, because they will try to regenerate the good flora within the GIT, so increase the immunity, increase the way the food is digested, and so on. So they reduce hospital stay, helps in quick recovery, and so on. So addition of these drugs even in small children is of help in reducing diarrheas. A few micronutrients that come to my mind when I'm talking of general treatments for diarrhea: vitamin A available as drops, even can be given to small children, and orally, of course, and they try to regenerate the epithelium that is been affected in cases of diarrhea. Addition of zinc, again, try to restore the epithelium, try to restore the losses. So addition of zinc also. In fact, zinc is in few countries, zinc is added even to ORS as a standard line of treatment for diarrhea. So it finds its own place when you are looking at micronutrients and how they can support in treatments of diarrhea. Now that was all about drugs. We have deliberately missed on other drugs, specific drugs and antimicrobials, because that we'll be talking when we talk specific cases of diarrhea. So I haven't been mentioning about traveler's diarrhea, infections, toxins, and so on, because I'll be dealing that in a few sessions to come, and not now. So that was all about generalized treatment of diarrhea. Again, to just revise on that, we just talked of ORS as the gold standard treatment. Again, it's not a substitute for IV therapy, so it is the treatment, I should say, for mild to moderate diarrheas, and it should be given because it has the potential to save life. Then we talked of a few other drugs, in which we talked of a major drug, that is Racecadotril, which again finds its own place whenever you are seeing the patient of diarrhea. Just affects secretions but doesn't affect motility. Antimotility drugs may be a drug of choice for chronic diarrheas, but not something of infectious origin. Again, Loperamide should be the drug of choice when you're looking at antimotility drugs and diarrheas. And a few other absorbents, which again doubtful as far as efficacy is concerned, and adsorbents like kaolin pectin, but few of them are banned in some nations. The preparations, again, Bismuth can be of use, and then we also talked about Octreotide, but again a very special case in carcinoid associated diarrheas and so on. So that was in general about treatment of diarrheas. I hope you like my quick recap on diarrheas and drugs for drugs for diarrheas. I hope to see your more likes since you have come so far. Listen to my entire lecture. Do keep watching my videos. Do subscribe. Your subscription matters to me if I need to continue on with my series of these lectures in clinical pharmacology. Do watch my video on viral gastroenteritis, because it's kind of an interactive session with few other doctors, which might add to specific treatments for viral gastroenteritis, especially in under 5. So I should say it's happy Sunday, right? So happy Sunday, not a weekend. Today I need to go to work. Tomorrow, okay, sorry. Today I need tomorrow. Tomorrow I need to go to work. Okay, bye.